Hello. We are going to now complete the remaining content from Chapter 12, Respiratory Disorders in Davis Advantage's Pediatric Nursing. This is part 2 of a 2-part Voiceover PowerPoint lecture. So if you're watching this one, the hope and expectation is that you have already viewed part 1, which is a separate video. We've already talked about what the objectives are for this chapter in the previous video. This was an illustration, available to you in the previous video as well, in which I explained kind of the purpose behind showing it is to help you identify all of the structure's location, as well as where it divides between upper and lower airway, because this will help you to better understand the manifestations and management for these different conditions based on where these structures are located and these disorders are affecting. So we already did talk about the lower airway in terms of what identifies it from the upper airway, but just as a recap, lower airway includes your bronchi, bronchioles, and alveoli, and then they typically group the trachea in with the lower airway, even though when we discussed upper, we said it was kind of the division between upper and lower. We did talk about there being 2 lobes in the left lung, 3 in the right, and that the left has a sharper angle. And that is all I'm going to recap on that, since the slide advanced. And if you recall, I cannot go backwards when I am voice recording, and the slide does that. So now we're going to talk about lower airway infectious disorders. And if you remember from the previous video, I grouped them by whether they were upper airway or lower airway, and then whether they were infectious or non-infectious. So this is going to be our first content or disorders that specifically involves the lower airway, and all of these are what we would consider contagious. And so one of the precautions that needs to be considered is how do we prevent spread, helping to hopefully reduce the likelihood of other kids or family members becoming sick with these disorders. Okay, so beginning with the first, bronchitis. Really, there is not much to say about this. I don't even have additional notes to accompany what this slide contains, because really and truly, what I need you to know is that this is a viral infection that is a result of inflammation of the bronchi that's best manifested or identified by wheezing, and that the kids that most often experience this are in the age frame of 1 to 3, which is basically our toddler age group. So typically with this, they're not as likely to have a fever, though that is still possible. And I think we talked about in the last video that, every child's different. There may be the typical presentation for a disorder or condition, but it doesn't mean every person's going to have the same experience. But typically, the way in which the patient is going to be observed as becoming ill is that they're wheezing, and that they probably have like a cough and a deepness to that sound when they cough. Okay, different from bronchitis, which is affecting the bronchi, which is the split that leads to the separate lungs. We also have bronchioles, which we talked about being the smaller branches off the bronchi. And bronchiolitis is what is more often going to be a more severe form of a lower airway respiratory condition. When we talk about bronchiolitis for purposes of this exam, this unit and content, we are using that word synonymously with RSV. RSV stands for respiratory syncytial virus. And so basically what you need to understand is that bronchiolitis by definition can be viral or bacterial. When it's viral, it could be due to a virus other than RSV or respiratory syncytial virus. But more commonly, if it's viral, it's going to be RSV that is creating that viral infection. And that is why the blanket term tends to be RSV. This is a good analogy or comparison to in our upper airway disorders when we talked about pharyngitis and how oftentimes that is basically strep, because when it's bacterial, it's usually streptococcus that's causing it, but you can have strep other places in your body besides your throat. And you can have other forms of infection besides streptococcus that causes you to have a sore throat, infection, inflammation. But typically, strep is the predominant origin, and so that's why those names go hand in hand. So when we're talking about bronchiolitis for purposes of this exam, for clinical purposes, while you're in nursing school, we are treating it as though it is a virus and as though the origin is the RSV or respiratory syncytial virus. Just be aware that it could also have bacterial origin or be viral to some other kind of viral infection. With this, the most hindering to the respiratory function is the excessive mucus that's produced and the spasms that occur in the bronchioles. So these bronchospasms combined with increased mucus production is what is interfering with the child's ability to have adequate ventilation. When you listen to this child, they are likely going to be wheezing, might even hear crackles. We talked about the adventitious lung sounds previously, but wheezing is associated with inflammation and it's air passing through inflamed passageways. Crackles is associated with fluid collection. Mucus production or mucus secretions typically have the sound of rhonchi associated with them. So really the potential for RSV is to hear majority of the adventitious lung sounds that exist. In fact, it could even progress to stridor, which we talked about being like wheezing, high pitch, but even more severe sounding, usually louder, higher pitch with inspiration, and it's associated with inflammation to the point of obstruction. Other symptoms the patient may have would be fever. They're coughing, but it's usually dry, though because of this mucus production, sometimes as it's improving, as the patient's recovering, they'll begin to have productive cough. Nasal congestion, they can have a very rapid respiratory rate, but they could also have periods with no breathing or what we would call, cessation of breathing or apnea. And it would be more like, I'm breathing rapidly. And I have that little, lull in my expiration and following that up with another inspiration. Okay, so what are we doing about either of these, bronchitis and bronchiolitis? Well, we said bronchitis was viral and bronchiolitis, we're treating that as viral, though we know that there is the potential for a bacterial form. So we can't do antibiotics if it's viral. We have to focus on supportive care. Remember, supportive care was covered in the previous video and includes our comfort measures to reduce pain, our fever reduction efforts to reduce the patient's body temp, our efforts to make sure the patient's adequately hydrated, nutrition as well so that they can get better. Rest even would be part of that. So supportive care would be a primary focus. The patient may require additional oxygenation. We likely would want them to experience humidified O2. So a humidifier might be used, especially with bronchiolitis, because of the mucus. And that way we can help to thin those secretions, making it easier for them to move and eventually be expectorated or, eliminated from the body. The patient may need nebulized treatments. Nebulized treatments is basically defined by the way in which the meds are given is through a nebulizer, which is an inhalation method using a mask that goes over the face and targets the nose and mouth, oral and nasal passageways. But the meds themselves could be a number of things. There can be just saline neb treatments that are just, basically humidified air that we're giving the patient. They could be albuterol. They could be epinephrine. I mean, that would not likely be the need unless the baby is having a very severe form. But you can, have nebulized many different medications in this family of drugs. Surfactant administration, it mentions potentially, would likely be in the case of like a really young infant that is diagnosed with RSV, because they may have had less surfactant production since utero to birth, so that might be something that could be done for them, especially if they're going to be hospitalized anyway. Chest physiotherapy, which we abbreviate CPT, is basically percussion on the trunk or the torso to try to break up secretions that are overwhelming the respiratory tract. So you maybe seen it where somebody's like used the palm of their hand and they kind of cup their hand and they beat on, and I say beat, but hit repeatedly on the back of the person. That's trying to, create kind of some pressure and a little seal to break up those secretions. They also make CPT tools or equipment. They have CPT wands, which are basically, the cupping element attached to some rod or stick to where you can use that. They have CPT vests. They call them oscillating vests that the child wears, and they're connected to a compressor, and you turn it on and basically it shakes the person, and that's helping to break up those secretions. And when you're using CPT or chest physiotherapy, you should probably also have suction available, because if we're breaking up these secretions, we need to be able to help the child expel them. They may be of the age and cognitive awareness to cough it up themselves, but some don't, in which case we need to be able, bulb syringe, suction catheter, yonker, whatever the case may be, but to remove those secretions that are being broken and moved around in the respiratory system. Nasal saline drops, similar to if we did like a saline neb treatment, would be to target the airway and help make sure it's moist, that we're helping to break up any of those secretions that have formed so that they can be expelled. Cluster care, which I know we've talked about before, but that's when we're going in to do things for the baby or the patient in a succinct amount of time, because we want to be able to allow them periods where they're not interrupted. So they get periods of rest, whether that's truly sleeping or just not having anything done that's gonna, aggravate or increase their symptoms. And then obviously preventing spread, because it is contagious. We do want to do that by teaching the family about proper hygiene practices, telling them to keep the child from daycare, from being around, siblings, especially any family members that are immunocompromised, because it increases the likelihood. Now, RSV is typically something spread between children. It's not often that adults experience RSV infection. So the likelihood of the parents becoming sick with it or other adults is rare, unless they have like some kind of immune compromise. But definitely small children, we want to try to, keep a distance until the patient's improving. So the last thing on this slide that you need to pay attention to is the medications that are offered or available as a prophylactic measure to reduce the risk of RSV in certain populations. And this is one of those things kind of like swimwear was with otitis externa, where I'll teach it till I'm blue in the face and someone's still going to miss it on the exam. But what I'm talking about with these medications is not a treatment measure for a diagnosis of RSV. It is a preventative measure or a prophylactic measure to reduce the likelihood a person's going to contract RSV or hopefully minimize the severity of RSV for that patient if they do end up sick with it. So for the longest time, the only thing available was what we refer to as Synagis. It's not technically in the vaccine family, though that's the most similar thing I can think of to tell you to compare it to, but it's its own, scientific substance, for lack of better words. It's weight dependent, so the amount that the child receives depends on the size of that child. And this particular one that was the only one for so long was given once a month during the length of the RSV season, which usually is essentially October till April or May. And so every month during RSV season, the child, or usually it was an infant or toddler, would receive 1 dose a month in injection form. It's an IM injection that was weight dependent. And this was to help hopefully keep them from becoming infected or to minimize the severity if they did end up sick. Now, the ones that could receive this were children who were premature and had at least one diagnosed chronic condition. And that condition usually had to do with something cardiac or respiratory related. And so those were the more vulnerable populations that we anticipated, not so much the only ones that would get sick from RSV, because that would happen with any child, but that would have the most severe complications, would require hospitalization, would have, a more, need a more aggressive treatment protocol than the average everyday normal child would. Now, there is an additional form of RSV prevention called Beyfortus. It's still a prophylactic preventative injection that's IM, but it's 1 dose for the entire RSV season. So you get it at the beginning of the RSV season and you don't have to repeat it every month the way that you would Synagis. And I honestly don't know for certain whether this one is weight dependent. I would expect that it is, but it's so new that, in my clinical practice, it was not available. It's come about really, truly in the last couple of years. And now they're even, and I can only tell you this because of being 35 weeks pregnant and having just had my doctor's appointment and received my injection, but now they're even giving RSV injections to mothers who are pregnant, gestational age between 32 and 36 weeks gestation, so that some of these antibodies can be transferred to the baby so that they have protection in the immediate time after they're born. So I got mine today, actually, so that, hopefully the antibodies are developed before I deliver the baby, and because of that, that maternal transfer is going to give the baby some protection until they're a little bit older and their immune system has started maturing on its own, or I've chosen, to get them their own protection from it. Synagis, you didn't have a lot of control over whether your child qualified because it required them to be a certain age of prematurity plus that chronic condition, but Beyfortus does not have that criteria. So you can pretty much opt to have your child receive Beyfortus regardless of whether they were full-term or early delivery, and regardless of whether they have any medical conditions diagnosed chronically or otherwise. So that concludes bronchitis and bronchiolitis. And now we're going to talk about pneumonia. Pneumonia, I hope, is very familiar to you. You've had it already in MedSurg 1, I would think. Patho, I don't know. It may have even been covered in some of your 4th semester coursework as well. But the things I want to draw attention to with pneumonia for pediatrics is, kind of more so what symptoms to be mindful of and which form, viral versus bacterial, typically impacts which population of children. So this very first bullet really is the primary thing to commit to memory. The symptoms are going to depend on the origin, and the origin means, is it viral or is it bacterial? It'll also depend on the age of the child, which also coincides with viral and bacterial. So for a viral form of pneumonia, that is normally going to be your younger child. We're going to see it more in younger kids, and the book doesn't give a specific age range, but I would basically tell you like your infants, toddlers, preschoolers, younger children, okay? They're going to have a fever, but that fever is variable, which means it could be high or it could be a low-grade fever. They're also going to typically experience a headache, which, again, depending on the age of the child, may or may not be something they can communicate. But that's one of the manifestations that they typically note. They have GI-related symptoms, like a stomach ache. That could also contribute to them not having much of an appetite or wanting to eat their normal amount. They are going to be tired. Probably nap more often, just in general be sleepier and exerted easier. They will have a cough, and that cough is normally productive, so they're actually able to get some stuff up with it. They'll likely have abnormal breath sounds or lung sounds, and with pneumonia, we think about fluid collection, so that's usually going to be crackles that we're going to hear, but it could also be wheezing if there's inflammation to those structures, as a possibility as well. The bacterial form of pneumonia in pediatrics is what we're going to see more in your older child, so I'd say your school age and your adolescent age child. And with them, the fever is usually high. So it spikes and it keeps climbing, and that patient is going to have chills, and you're going to be able to feel the fever. You're going to be able to see the sweating, even though they might be shivering with that. So bacterial typically has a higher fever associated with it. They will probably have the adventitious or abnormal lung sounds like the crackles we mentioned, but they could even have diminished lung sounds. That's what the decreased is referencing. So they may not be breathing as deeply, that may be more shallow breaths, because they may not have as good of oxygen exchange, and so again you would expect that to relate to some diminished lung sounds. They're going to cough, and your book doesn't specify if bacterial's coughing is productive or not productive, so that won't be part of the question, but coughing in general is something that you can anticipate, and like I said, it's for the older kid. So when a patient experiences pneumonia, they are having an impairment in gas exchange. Our focus needs to be supportive care, and that would apply to both origins, bacterial and viral, but also if bacterial, antibiotics. And most of the time, they can be treated outpatient, so they can be sent home on antibiotics unless they're severe enough to need, more continuous monitoring, potentially IV related medication administration, or supplemental oxygen that the family isn't wanting to do from home. Supplemental O2 is definitely a measure that an inpatient with pneumonia is going to receive. CPT is that chest physiotherapy again, which we said, you have to pair that with suctioning after the fact. And knowing that we want to strongly encourage maintaining up to date on immunizations, because that can significantly decrease pneumonia. The pneumococcal vaccine is not just for pneumonia, but that's one of the things that it's going to help reduce the likelihood of. And there are other vaccines that still contribute to minimizing pneumonia infections as well. Okay, pertussis, it has an alternative name that we know as whooping cough. Pertussis should sound familiar to you. It's part of the Tdap, also the DTaP vaccinations that are given to children, both early childhood and adolescence. So from infancy through about age 4, the child's receiving numerous doses of DTaP, and the P in that is pertussis or whooping cough. Then the child turns 11 and they get a Tdap, still the P, meaning pertussis. And then at every 10 years from that point forward, they get a booster Tdap, which has that booster protection of pertussis in it as well. So whooping cough, the whooping description is based on the sound that's often heard when the child's experiencing these coughing episodes, and it sounds like a whooping sound. I'm not going to attempt it. You can Google that, YouTube or whatever, to get a sound clip. With this patient, more often the coughing attacks, episodes, spasms, all of that is happening at nighttime or in the evening, especially when the child's trying to lay down and go to sleep. And it's probably because of the position they're in that allows it all to, kind of gather in one place, but it typically is worse at nighttime. We see this mostly in spring and summer months, so it's opposite what you would think for typical respiratory infections, which are fall and winter months. This is spring and summer. And this cough lingers, like even when the child's essentially back to normal and, their appetites improve, they don't have a fever, they're not experiencing, mucus or production of anything when they're coughing, but the cough itself will stay. And it literally can last up to 10 weeks. You'll often hear it referred to as like a nickname as the 100-day cough. Okay, and this is not just kids. This can happen in adults too. But when we see it in children, it's usually kids 10 years and younger. So it would be our school-age kids on down that are more often going to have it. Our measures for management will be supportive care, supplemental oxygen, likely humidified, and again with the encouraging of immunization compliance, because like we said, this is preventable with the proper vaccinations. Okay, tuberculosis. You're going to have this more in MedSurg 2. The primary thing that I want to speak to with it in terms of pediatrics is that it is not a common thing in pediatrics, and it is not as severe in kids as it is in adults. So when you hear about TB, it's rare for it to be detected in a child, and it's also not as severe or life-threatening. Like for me, I think of Moulin Rouge every time I hear tuberculosis. If you've never seen it, you need to do that when you're not studying. But it's not the same level of severity as it is for the adult. It's hard to diagnose because a lot of its presentation or symptoms align with other conditions too, and again, it's not one that you would expect to be prevalent. The child typically experiences weight loss, or they have trouble gaining weight. So they may have an appetite, they may be eating, a balanced nutrition, but they're not putting on weight, or they may even be losing weight. They are likely to experience sweats at night or night sweats routinely, adventitious or abnormal lung sounds that include wheezing and diminished lung sounds, especially with our babies. But something that differs that you would think of TB with the adult that doesn't apply to the child is the coughing up of blood. Like if you think of TB, at least me, because of the media, movies, I think of a handkerchief that's white and the person start coughing and there's red blood. on the handkerchief. That is not a manifestation that pediatrics exhibit. So what would be essentially a telltale sign for the adult is not the indication for the child. These individuals would need to be in a negative pressure room for management because of the airborne contagious potential, and they would be, like an adult, receiving a multimodal therapy, a 4-drug combination. It would just be different, doses than what the adult receives for that. So those are some things to be mindful of with tuberculosis. COVID-19. COVID-19 has definitely, I would imagine, been something that you've heard enough about in the media through nursing school, maybe your own personal experiences, that it is typically worse in adults than it is in children, and it's worse in adults with comorbidities than it is the average adult. So as far as kids are concerned, one thing is that typically the symptoms that they do align with what adults experience, but they're much milder. There's usually not as many symptoms, and they can actually be different in origin than what the adult's experiencing. It can result in what they've referred to as multisystem inflammatory syndrome in children. They abbreviate MIS-C or -C, which is kind of like a complication of COVID-19, is when it's impacting numerous systems of the body in this syndrome kind of capacity. It can be both upper and lower respiratory tract. So we've got it grouped with the lower airway infectious disorders, but it can involve the upper airway as well. And multiple organ systems. There is a vaccine available for kids that are 12 and under that they can receive as prevention or protection from it. And there is a treatment measure called, I actually don't know the pronunciation. I'm going to assume it's Paxlovid, but it's a medicine for an antiviral for the diagnosis. Okay, so that would be the conclusion of our lower airway infectious disorders. Now we're going to look at lower airway non-infectious or not contagious disorders, and there are 4. So the first one is respiratory distress syndrome, which is abbreviated RDS. I'm going to tell you the way to best remember this one is it is associated with prematurity. So when you hear about RDS, this particular, it's not just a patient who's experiencing respiratory distress, it's its own medical diagnosis called respiratory distress syndrome. And one of the criteria is that the baby be premature. Now, we talked about how prematurity can vary depending on the resource you're looking at. Like technically anything younger than 37 weeks gestation is prematurity. But with this, we're looking at the very preemie babies, usually 28 weeks or younger. So remember we said viability was 24. So this would be like those babies between 24 and 28 weeks gestation that are more inclined to have this diagnosed. It's associated with immature lung development, and a lot of that because of them not having the optimal amount of surfactant because they were born early. The signs or the manifestations that we're looking at are going to be there from the time the baby is born. So they're going to have distress at birth. They're likely going to go to the NICU. Their APGAR score is going to be low initially. They may have the audible adventitious lung sounds, primarily crackles and rails, which are fluid related. They're likely be tachypnic or have a very high respiratory rate, something exceeding what is actually the norm for a newborn, which is 30 to 60, so it'd be even higher than 60. And they may be demonstrating some accessory muscle use like retractions. The baby in the NICU will need to be ventilated, probably intubated, receiving surfactant administration, and receiving supportive care. But eventually, with enough time, their lungs will begin to strengthen and mature, and they won't have to stay in the hospital. These are babies that typically do get discharged on supplemental oxygen. So they may go home and be with family, but they still may require some of the interventions that would have been done or were done in the hospital too. If an infant, and this is a important reference that we'll see again, if an infant continues to need supplemental oxygen past the point of their gestational due date. So let's pretend a baby was born at 28 weeks. They were hospitalized in the NICU. Now they are 12 weeks old, okay? Which means they have reached the age that would be full-term gestation. As they're 12 weeks old, they were born at 28 weeks. We add those two numbers together, we get 40 weeks. So now they're to their full-term date. If they are still needing supplemental oxygen at this point in time, whether that's in the NICU or being discharged home with it, then their diagnosis is going to transition from RDS, respiratory distress syndrome, to BPD, bronchopulmonary dysplasia. So then the reverse is true. BPD is a chronic form of RDS. So basically, you get the diagnosis BPD if you already had the diagnosis RDS and it's not resolved by the time the child is gestationally full-term 40 weeks. If that was confusing, just listen to it again. Okay, the next condition is acute respiratory distress syndrome. So the same name with one additional word and one additional letter to the acronym or the abbreviation, and that's ARDS, acute respiratory distress syndrome, ARDS, pronounced ARDS. ARDS can occur at any age. So this is not just talking about your premature babies, 28 weeks gestation and younger. This could happen at any time. This is basically like an event where all of a sudden their respiratory function is severely compromised. I don't remember which chapter it would have been in. I'm guessing newborn infant, but we had ALT, ALTE, apparent life-threatening event, and we were talking about that combined with BRU, brief unexplained respiratory event, something like that. And that was all like kind of in correlation with SIDS and SUID. So with this, ARDS, the age of the child is not specific, but what's happening is there's some kind of trauma or injury to the respiratory structures. So like a drowning incident that the child's rescued from, a smoke inhalation incident where they were like in a house fire and they got out. Severe infection like shock or sepsis can do this. And basically the degree of trauma or injury the patient's experiencing is impacting their respiratory system or their respiratory structures. What usually happens for this patient is it progresses to respiratory failure. They have all of the indicators of distress that continually worsen, and all of the evidence of distress depending on their age, like nasal flaring I would expect with the infants, but obviously tachycardic, tachypnic, all of that. And you're giving them supplemental oxygen, so you're using administration of additional O2 as a intervention, and it's not helping. That's not improving the patient's respiratory functioning. So that is when we've said, okay, this is a trauma or an injury that isn't responding to the typical measures for intervening. Okay, cystic fibrosis. We talked about this. I don't actually know what order you're getting this content in, but this was also covered in the gastrointestinal chapter 16, because CF affects both the respiratory system and the gastric system. So I don't know to what degree, I don't recall to what degree I lectured this information, but just know that cystic fibrosis is something that affects both systems, so it shows up in both chapters. And we're talking about it and testing on it from both perspectives, the respiratory side of it and the gastrointestinal side of it. Okay, CF is a very common cause of death in children. It is associated with overproduction of mucus and not enough or underproduction of pancreatic enzymes. Because of this, the patient becomes malnourished, and it's because the enzymes that are responsible for digesting all the nutrients and absorbing them are being blocked. The enzymes are not functioning properly, or they're being blocked, and it's not allowing them to do their job. It's affects multiple organs, which we talked about, stomach and lungs being some of those. That can result in damage that's not reversible, and that can ultimately lead to death in the patient. These individuals are immunocompromised, which means they're going to be prone to infection. They're chronically infected. This is a chronic health condition. The patient usually demonstrates or appears with a protruding abdomen, but very thin extremities. So they're not proportionate in their weight variability, but they'll tend to have that distended abdomen, but then be very petite elsewhere. The patient can also experience digital clubbing, which means finger clubbing. That's associated with hypoxia or low oxygen in the tissues. Lung sounds like crackles and wheezes, but also could be rhonchi, and salty skin, steatorrhea, which is like the fatty, bulky stools that will actually float in the toilet. And then these patients, one of the concerns is that they could possibly be sterile or infertile later in life. Children with cystic fibrosis have a higher drug clearance, which means that they excrete the medication easier and faster, which also means that a lot of times their medication doses have to be higher than the average for them to be effective. These individuals are supposed to avoid taking antihistamines because antihistamines have a drying effect, and with all of the mucus production that they're experiencing, if it's dried out, it's going to make it harder for it to be eliminated. So we don't want them to have that, complication. We want them to be able to expel any mucus secretions that are building up. Pancreatic enzymes are going to be required as a supplementation, and I think this is spoken more about in the GI, but I have it on the notes here, so I'll speak to it here too. But they are only effective for about 45 minutes to an hour after they're consumed, so they should be administered when the patient starts eating a meal or a snack. That will have the greatest impact on digestion and absorption. Whereas with gastroreflux, we were given the meds 30 minutes prior to them eating so that they would already be in effect and hopefully reduce the heaviness that the food creates for the patient in their esophagus, and reduces complications like vomiting episodes. But in this case, we're talking about pancreatic enzymes. That's given with the start of them eating something so that it has a duration through the time that they're eating and the aftermath when it would need to be digested and absorbed. Okay, asthma. Asthma, probably the most common chronic respiratory condition that exists in pediatrics. It is associated with inflammation of the airways and specifically bronchospasms. It varies from person to person, and there are different triggers for different people that, make it worse. So some examples would be like smoke, exercise-induced asthma, pet dander, molds, all of those things. But, it's not the same for every person. But with asthma, a lot of which the patient's going to experience is going to be coughing fits or coughing episodes that are hard to interrupt and catch your breath from, especially at nighttime. That's when they're usually worse. The child is likely to be wheezing, especially if they are like overexerted. They'll have complaints of shortness of breath. They'll have a prolonged expiration. They may even be demonstrating some retractions. In infants, one of the ways that distress is depicted besides nasal flaring is head bobbing, like they're, moving around because they're trying to take in adequate breaths. These individuals will require an asthma action plan if they're in school. And in that plan, it basically spells out these different zones, green, yellow, and red, that when these symptoms happen, they're considered this zone and they need this treatment or this management for this patient. So it might be like with green, we don't need anything. With yellow, we might be having coughing fits that exceed 10 minutes. And a pulse ox that drops to XYZ number, so they need however many puffs of their albuterol inhaler. If we're in the red zone, we might need our inhaler for 4 puffs and then to go to the ER, because this is just a temporary fix, what we're doing for the patient. So that's going to vary by person. Inhalers and nebs, or nebulized treatments, are the most common medication management that the patient's going to receive, and the drugs for that are typically albuterol and Xopenex. Those are our fast acting or short acting, which means that they're given with a acute episode, whereas there are other meds that are long acting that you give as more of a preventative to keep them from having an exacerbation or a flare up of their asthma. Inhalers, when the child is young, should also involve a spacer. I wish I had the supplies with me. They're in the sim lab, but a spacer is this plastic chamber that connects to the inhaler, and basically the other end of that spacer has like a little either mouthpiece or a little face mask piece that you place on the child's face, or if it's the mouthpiece, then it's in their mouth. And then here's this chamber, and then here's the inhaler on the other end that the provider or the nurse or caregiver, whoever, is squeezing the inhaler and delivering the puffs. And it's basically, the spacer is a barrier to keep the patient from tasting the medication when it's sprayed and from being stunned or caught off guard by the jolt when that med is delivered, because this way that all occurs in the barrier in this spacer, and then the child just takes normal breaths a few times, and that allows them to receive the medication's benefit. Okay, we're doing great. I'm obviously getting tired of sitting, hence the up and down motions you keep seeing. Let's get a little bit of water. Okay, more than halfway through. Non-infectious disorders. So we've now had our lower airway infectious and non-infectious. Now we're not really being specific about lower versus upper. Everything else that we're going to talk about, it can have some impact on all of it, on the airway in general. So it wasn't categorized as upper versus lower. But with all of these, they are considered non-infectious or not contagious conditions. Starting with the first one, foreign body aspiration, also known as foreign body obstruction. So the abbreviations for these would be FBA or FBO. You'll likely hear that. And anytime you see like the abbreviation FB, it's usually for the words foreign body. So with this, there is an occlusion of the airway associated with the foreign object. That could be an edible object, like something that they ate that got stuck, like a nut or a hot dog or a grape or some popcorn, whatever. Or it could be an object that's not edible, like a small toy or a coin or a piece of a balloon, battery, okay, all different potentials. Regardless of what the object is, it's now been, aspirated into the lungs, or it's obstructing somewhere along the respiratory tract, and I'm having trouble getting it up or getting it all the way down, and so I'm having symptoms associated with that. We see this the most in infants and toddlers because of their tendency to put everything in their mouth and to not know the dangers of choking. But even some young preschoolers will do this as well. Remember, infants experience the oral stage in terms of Freud, and that's part of their development and exploration is they evaluate everything with their mouth. The increased mobility is also a reason because they have more access once they learn to crawl and scoot and roll and pull to stand, and walk. So they have more access than when they were laying, on their backs or bellies and not really able to go anywhere. What will they demonstrate as far as, symptoms? The severity of which is going to depend on where did this object end up landing or being lodged. But obviously they're going to be coughing. Choking, they could, demonstrate with the universal sign. Gagging, potentially, as they're trying to get it out. When you listen to their lungs, if it's to that point, then you probably are going to hear audible wheezing. Stridor is typically going to be what that wheezing progresses to. Remember, that's what we said. They're like similar. They're both the high-pitched whistling sound, but stridor is obviously indicative of a worse compromise or more severe respiratory distress for the patient. Cyanosis, so it could obstruct oxygenation enough that they actually become cyanotic, and that can be observed in mucous membranes, on the face, on the nail beds, lips, all of those places. What we want to focus on is getting that object out. So, Heimlich maneuver would be an option if the child's older than a year. If they're an infant, so younger than 12 months, we would actually put them on the provider, caregiver, nurse, whoever's arm, and we would lay them, stomach to arm, so that on their back we can hit what we call back blows, and then we can change the child's position to where now they're on their backside and I can see their anterior position of their body, I can see their mouth, and I can do abdominal thrust to try to, get that object up and out for that patient. But that would only be doable on an infant, especially a lighter weight infant. If they're not somebody that I can handle their weight on my arms like that, then I'm doing, the typical Heimlich maneuver efforts on the person. So CPR would be, if it gets to the point of them stopping breathing altogether, or obviously if their heart stops, then I would progress to CPR interventions for the patient. And obviously our biggest goal here is prevention. Like, we want to make the family aware of what are some of these most risky items and try to, teach them about safely securing those things out of reach so that this doesn't happen to begin with. A rule of thumb: if an object can fit through a toilet paper roll, the cardboard insert to toilet paper, it could be swallowed. Now that, of course, does matter as far as the child's age and size, But, I would be leery to allow a child to play with anything that could actually fit through a toilet paper roll because that potential is there for choking on it. Okay, BPD. We already talked about bronchopulmonary dysplasia when we talked about RDS. Remember, respiratory distress syndrome was one of our non-infectious lower airway conditions, and we said that it involved premature babies, usually 28 weeks and younger, and if that preemie still needed oxygenation supplemental O2 past the point of their due date or their gestational age in which they would now be 40 weeks, then the diagnosis becomes BPD. So this is the slide explaining BPD. This happened, actually a student came up with this for me, which is just awesome, a few years back, that you could think of BPD as, it obviously stands for bronchopulmonary dysplasia, but you could also think of it as babies prematurely delivered. Now, it's not all premature babies, it's the ones that are really young, like the 28 weekers and younger. But it's associated with immature lung development, with premature delivery, with decreased surfactant, and with chronic issues to the respiratory system. The patient has this distress and accessory muscle use with abnormal breath sounds, weight loss, difficulty feeding for a time, probably that whole next month or two. The patient's continuing to need supplemental oxygenation, maybe even being ventilated in order to maintain a patent airway. And they're probably receiving medications, and they may need cluster care to still be allowing for periods of rest. So those meds could be anything from surfactant to steroids to bronchodilators, even caffeine, which we're not talking about like giving the kid a Coke or a shot of espresso, but there's like medication caffeine, which helps to stimulate the respiratory center and the central nervous system and improve the breathing abilities of the child who has this particular diagnosis. We want to monitor their fluid intake and output. These individuals may need diuretics to keep them from having fluid overload. And so anytime a diuretic is being ordered, obviously we need to be paying attention to intake and output in that situation too. The ensure strategy comes from your textbook. It basically is the first few letters of the following three words: intubation, surfactant, and extubation. So these individuals, they are going to be intubated at birth. Remember, this is our babies that we're giving the diagnosis of RDS to. They're going to need that surfactant replacement, along with oxygenation, the ventilator, all the things. And then the goal eventually is to extubate them and to where they don't have separate needs. They can just kind of fall in with other kids with chronic respiratory problems. So RDS unresolved by gestational age is what becomes the diagnosis of BPD. You will likely see the patient who has this, their medical history will change from RDS to a history of RDS, and then the diagnosis of bronchopulmonary dysplasia. Okay, apnea is when the patient stops breathing for more than 20 seconds or has any interruption in breathing that results in them having demonstrated respiratory compromise. So they have to stop long enough for it to actually, have an effect on their color or their oxygen saturation or their level of consciousness for it to technically be an apneic episode. When it happens in prematurity, this is normal. And this doesn't have to just be 28 weekers and younger. This can be, any baby that's born before 37 weeks gestation. It's typical for them to have what we know as apnea prematurity or AOP. But it usually goes away on its own, and usually, within that newborn period, which for most kids is, the first month of life. Obviously, if they were severely premature, like 26 weeks, then it might be the first couple of months that, you would see some tendencies, but eventually it would self-resolve. With this, the infant may startle while they're sleeping or even snore while they're sleeping. If it's suspected, one of the things that can be done as far as management is for them to undergo a sleep study, and that would give a better idea of how frequently it happens, the severity of it, if it's truly impacting the patient's vitals enough to need to intervene. Weight loss may occur for this patient, especially, if they're... So one of the things that can happen is they tire more easily with breathing because of their immature lung development. So then, because of that, they may not have the energy excess to be able to eat appropriately, in which case they won't gain or they could lose weight. And we want to definitely monitor to determine what's causing it and how it should be managed. Okay, ALT, or apparent life-threatening event. I referenced this earlier. Also known as a brief resolved unexplained event, BRU. This is when there's some form of respiratory compromise in a baby that we don't know the cause of. So with this, the patient survives. It's not a fatality, but we don't understand why they had this severe respiratory compromise to begin with. So it basically requires the providers that are diagnosing the patient to try to eliminate all other possibilities. So what we would call like a differential diagnosis, or a diagnosis differential, where you're going through and saying like, it's not this, it's not that, it doesn't make sense to be this, etc. But with this, for this to have been what the patient experienced, then there would have been visible changes in the baby, like color changes, pallor, paleness, or cyanosis, their breathing pattern becoming irregular, abnormal, them even having muscle tone changes, like usually more flaccid, more lethargic, more run down, that kind of thing. These babies would need to be monitored closely with both telemetry and pulse oximetry. So they would have leads on their heart, and they would be wearing a pulse ox, which is keeping track of their heart rate and their O2 saturation. And we want to definitely make sure that the families are educated on what are safe sleep practices, what does this continuous monitoring entail, what are feeding measures that are appropriate for this baby at this time in their development. Pneumothorax. Pneumothorax is when a patient experiences a lung collapse and air is being trapped by this trauma. We see this very often in newborns, and we see it again in males that are in their adolescent period. It is life-threatening. When you suspect this, you will likely notice that the breath sounds are diminished or much quieter on one side of the body or one side of the lungs. They could be absent even. But the remainder, the other side of the body or lungs, you can still hear lung sounds with them. The trachea is likely deviated. Whatever side the lung has collapsed on, we would expect that the trachea be deviated to that side. They may complain, the patient, of chest pain that's located in their shoulders. It's radiating to that, but it's actually, initially forming in their chest. Since newborns are typically the age that demonstrate this, you would expect the grunting, nasal flaring, visible retractions, pallor, cyanosis, and their O2 sat to drop. They will need oxygen supplementation. This baby is going to need some kind of intervention to release the air that's being trapped and allow the lung to expand again. And there's two ways that can be done. One is with a needle procedure, and one is with a tube insertion. So you've got thoracentesis, where a needle is introduced to let the air escape and let the lung that's collapsed open back up, or a thoracostomy, which is a chest tube being inserted to let the air escape and the lung then reinflate. And it's generally the size of the pneumothorax and location that dictates which of these is going to be attempted. Sudden infant death syndrome, or SIDS, which is now being referred to as sudden unexplained death of an infant, or SUID. They are synonymous. One is an older abbreviation, one is the current. With this, the things to consider are what are the risk factors and how do we support families that, these risk factors apply to them, and try to offer them community resources to ensure the safety of their child. This is going to be only associated with deaths of a baby younger than a year old, and it's when they die essentially unexpectedly from an unknown cause. A lot of times they're found already deceased when they've been napping or when they were asleep, like during the night. They don't have a pulse or respirations, and to really know what was the cause would require an autopsy for them. We see it, unfortunately, the most in infants between 2 and 4 months old. And so we want to spend a lot of time educating and supporting and providing counseling on all the reasons that safe sleep matter and that these practices need to be known and implemented for each baby. I'm not going to get in depth on that because y'all had it in OB already, or you will. But things like a firm mattress, not having any loose bedding in the bed with the baby, no toys, nothing that's going to potentially suffocate or prevent the baby from, turning their head and breathing adequately. Oh, smoking and vaping. We're taking a different direction now. So this is obviously less likely our young children. This is more of our adolescent population, and in this day and age could even include our school age population. But I don't have additional notes on it, just what the slide explains, that they need to know the dangers and risks. They need to know that, starting this can create a habit that's hard to break, that, even temporary participation in this can have detrimental effects on the body. But of course, chronic use is even worse for the patient's organs. What those effects can be, need to be discussed. Like, what can it do to the body and organ systems that would impact them long term? And what are some resources that can be offered to help them quit if they've started? May involve, a social worker, support groups, seeing a counselor. Depends on what got them into the habit to begin with, and how old they are and how often they're doing it will kind of dictate what recommendations are made moving forward. Okay, and then I think the last couple of slides speak to just a general element of nursing education associated with respiratory assessment and respiratory intervention. So this slide is speaking to noticing the differences in the color of the skin and what that means, how we suction, how we obtain a proper placement of a pulse oximetry probe and get accurate readings when we give supplemental oxygen to a patient. So we definitely want them to always have an SpO2 or oxygen saturation of 92 or higher. I talked about last recording that it's not normal to expect 100% O2 saturation on a person, that 95 and higher is great, but definitely want it to stay above 92. We want to monitor their pulse oximetry using the sensor in the appropriate way, and this picture on the slide talks about where you place the light sensor portion and how sometimes it doesn't work on a finger. You need to use the palm of the hand or even the sole of the foot to monitor the patient. Blood gases are a great way to determine what is the most accurate oxygen saturation for that person. Humidified oxygen is an intervention that might be needed in addition to supplemental oxygen in general. We know that there are different delivery devices, and I think we kind of spoke to this with the part 1 of the respiratory chapter, but we have the nasal cannula, which is like least invasive but also least effective. It only has the ability to deliver between 1 and 6 liters a minute. So it's probably it's what we consider our lowest flow and our lowest percentage of oxygenation. From there, we go to the face mask, which can deliver between 6 and 10 liters per minute. So it is a higher flow and a higher percentage than the nasal cannula, but it's still not the highest out there. Non-rebreather would be the highest. That is the face mask that then has the bag attached to it. With it, you can deliver between 10 and 15 liters a minute. So this is what can potentially allow you 100% oxygenation. It has the highest flow and the highest percentage of O2 that's administered. The Venturi mask, even though I'm speaking about it last, does not actually trump the non-rebreather. It's got a different purpose entirely. The Venturi mask's big advantage is that it can be titrated very precisely and will then or therefore minimize the risk of carbon dioxide retention, which is really important in certain patient populations like COPD patients, for example. So some tips that you can take from this image here: place the light emitter portion of the probe on top of the hand, foot, or finger. Light emitter should be directly opposite the photo detector of the probe itself, and this is to get an accurate reading. For infants, the best site would be palm of the hand or of the foot. So palm of hand, sole of foot. And there's some pictures within this that can kind of show you the proper wearing it. Okay. So this is a recap of all of the lower airway conditions we talked about today. Kind of a recap that there are over-the-counter meds that can be effective for kids. One of those things being prophylactic or preventative measures like Synagis, Beyfortus, the one that's given for pregnant women. I don't remember its name, but I know Pfizer's the manufacturer. Who qualifies for those things, how frequently it's needed. Let's see what else. Whether it's weight dependent for dosages or if it's, just a standard one size fits all. Hand hygiene, being taught at a very young age and enforced, and then childhood vaccine compliance being a important education topic for discussion. Cystic fibrosis, remember we talked about it as being a disease that, in layman's terms, it makes the body sick with thick, sticky mucus that affects lungs and digestive system. Its buildup and side effects can actually clog the lungs and obstruct the pancreas, preventing digestion and requiring, frequent intervention. The inability to digest and the continued, stasis of this mucus is what becomes a habitat for bacteria growth and causes frequent infection or sickness for the patient. They would have a salty taste to their skin. Their abdomen would typically protrude or be distended. They'd have bowel obstruction. Stools would be greasy, bulky, and float. They may have barrel chest or air trapping that's demonstrated in a protrusion of the chest. Their fingers and toes may club. They would likely have a wet cough that's lasting several months, but it could also result in adventitious lung sounds like wheezing, crackles, shortness of breath. They could have poor weight gain and be failure to thrive. I have on here like the true definition of CF is inherited autosomal recessive disorder of the exocrine glands that results in alterations of the respiratory, GI, and reproductive systems. Vitamin deficiency, electrolyte imbalance, poor weight gain, failure to thrive, not digesting food and absorbing nutrients, infertility affecting the reproductive system. And then what would our treatment and care be? Maintaining respiratory functioning, utilizing chest physiotherapy daily, utilizing neb treatments. The oscillating vest is an option for CPT, managing infection, giving antibiotics if it's bacterial in origin and anti-inflammatories, promoting nutrition, making sure they're on supplemental vitamins and other, supplements, all of which are appropriate for this. The patient, this is chronic CF, so, giving them support psychosocially and in the community. They may even end up on the lung transplant list at some point in time. So those are some examples. I don't know why, but then it goes into asthma medications. So I'm just going to see if there's anything I hadn't already said about asthma meds. They're targeting the airway to provide easier supports. They can be in the form of a nebulizer, inhaler, or oral meds. Some of the daily inhaled corticosteroids would be Pulmicor, which is budesonide, and Singulair, which is a leukotriene receptor antagonist. This would be to help with daily control of asthma that's persistent. Then we have our short-acting beta-2 agonist. That's our albuterol, our Zopanex, and our other anticholinergics like Atrovent, which is for quick relief. So it'd be really good to review the meds that are geared towards daily consumption and prevention of episodes versus meds that are given in a acute capacity that have the ability to quickly relieve the distress the patient's experiencing. Okay, and that's it. So that concludes Chapter 12, the Respiratory Disorders. This was part 2 of a 2-part voiceover PowerPoint lecture that covers upper and lower airways disorders that are both infectious and non-infectious, plus some additional information that didn't really fall under either category. Excuse me. So if you have any questions, it would be a great time to reach out to course faculty with those. Otherwise, you should now have the information you need for respiratory. Don't forget to also review the information for gastrointestinal. And there is an assignment that is not edge quizzing. That is the grade for this unit that's available on Canvas. Okay.